floor is yours.
Thank you so much, Nicole. I am so excited to be here with you all and share with you today's topic of conversation, something that I hold very dear and near, is assessing and addressing polypharmacy. And we're going to be looking at that from the nurse's perspective and for the population of those with serious and advanced illness. And so after completion of today's presentation, each person will hopefully be able to define polypharmacy, discuss the prevalence and implications, better understand the hospice and palliative nurse's role in polypharmacy, review evidence-based tools that are used to assess, review communication techniques that we use to discuss and communicate our concerns and assessment, as well as discuss deprescribing in a safe and efficient manner. We will also hopefully be able to demonstrate the knowledge of the nursing approach and process through polypharmacy. And so what is polypharmacy? By definition, there's an awful lot of definitions out there, but this one we're going to use for today's presentation. Polypharmacy is the use of multiple medications to treat a single ailment or condition. So that's a pretty vague description of what is really a huge problem for majority of our patients. And so how many medications is too many? Well, there was a systematic review that was done. So some research was done in 2019, and it looked at 1,156 articles. Out of those articles, 110 used a numeric definition of greater than 5 medications. And so again, for the purposes of today's presentation, we're going to use polypharmacy is going to equal greater than 5 medications. But there's a lot of research that shows that patients with polypharmacy can have anywhere from 2 to 11 medications. And so again, if we're treating one single ailment and we have 2 medications for that one single ailment, such as hypertension, it would be by definition that that patient has polypharmacy. And so the fall down of measuring polypharmacy with only one variable, that numeric number, does not take into account, or it excludes that patient-centered approach, right? And so we want to be very mindful of, would it be safe to presume that polypharmacy includes 2 medications for one person? Chances are low, but 11 medications, chances are pretty high. So there are several challenges that polypharmacy creates. Multiple medications can increase drug-to-drug interactions, which can cause adverse events and ultimate negative outcomes and risk of harm to our patients. Other challenges include drug-to-disease interactions, and this happens when medications are given in the presence of end organ failure. So that means that kidneys and liver aren't functioning as well as they did before, and there could be also some GI issues that happen with just normal aging, and all of that can increase toxicity or risk of harm for patients. Polypharmacy also has a high cost to consumers and the healthcare system. Medications are not cheap. Patients who took 11 or more medications reported high symptom burden and poor quality of life, suggesting that polypharmacy actually increases suffering. And polypharmacy is very much aligned with the medical model. And as we know, medical model can at times also increase suffering closer to the end of life. So polypharmacy also conflicts with the hospice and palliative care model of providing that holistic patient-centered approach and using non-pharmacologic interventions when appropriate and for first route of intervention. And I always like to remind those of us in the healthcare field that our bodies change. And so as our bodies change, it would make sense that our medications change also. And this is very important as we near end of life and we get closer to needing the most important medications in the event of organs decreasing. Also, another pearl that I like to share is that after the age of 40, we start to lose 10% of organ function per decade. So at the age of 50, our kidneys and liver are 10% less effective when they were in their 20s. And so certainly lifestyle modification is going to help to support slower aging or faster aging. So the prevalence of polypharmacy, this is a global health concern, so much so that the World Health Organization in 2022 reaffirmed their initiative that they set out in 2017 to have a global patient safety challenge of medication without harm. This initiative called on stakeholders to prioritize and take early action in key areas associated with significant patient harm due to unsafe medication practices, including high risk situations through transitions of care and polypharmacy. This campaign has four objectives to raise global awareness of the high burden of medication related harm and medication errors, as well as unsafe practices, and to advocate to improve medication safety. The initiative also would like to engage key stakeholders and partners in the efforts to prevent medication errors and reduce medication related harm. They also want to empower patients and families as well as colleagues to be actively involved in safe use of medications and to scale up. And so the scale up means to apply this, to implement it. And so that is a challenge that we are facing globally. And so who are the patients who are at highest risk? Well, it's the older population, folks who are older than the age of 70. Also, women and women with cardiovascular disease are 39% likely to have polypharmacy compared to our male counterparts, who are 32% likely. And that data was taken using the Beers criteria, which we'll talk about a little later. Patients in long-term care are also at high risk. The longer the patient stays in long-term care, the more likely they are to be prescribed more medications. And so one study showed that at the time of admission, average patient came in with 6 medications, and at the time of discharge, the patient had 8 medications. And so discharge also includes death. Those who are at increased risk are people with advanced dementia. And so half of people with advanced dementia are taking 4 or more medications, and 80% of those living with advanced dementia in long-term care suffer from polypharmacy compared to those who have advanced dementia and live in the community and are at a younger age of diagnoses. Most medications are discontinued 4 days prior to death, and that's when we begin to see that death is imminent, patients lose their ability to swallow. Beginning to have conversations about medication appropriateness from a holistic, patient-centered perspective will proactively enable us to impact and provide a palliative approach to medication management, which will ultimately help provide our patients with safer care, and especially those patients in the vulnerable populations. And impacts of polypharmacy, just to recap here, include poor quality of life for patients, increased drug-to-drug interactions, also putting extra drugs out into the community that don't necessarily need to be there, not just focusing on the high-risk medications, but just medications in general. There's also the high risk of adverse outcomes, including increased lengths of hospital stays and readmission to hospital soon after discharge. Excessive medications negatively impact the quality of care at end of life, as well as increased caregiver burden. And so watching side effects or a poor effect from a caregiver perspective just elicits feelings of hopelessness in an already situation where hopelessness is already apparent. There's also the high monetary cost to our healthcare industry, and for these reasons, deprescribing frameworks are needed to empower healthcare workers to adjust, individualize, and optimize medication regimens, and should be a part of embedded guidelines. So where does the hospice and palliative nurse fall into this? Well, the hospice and palliative nurse is the gateway, and all nurses are the gateway to safe patient care. Polypharmacy identification and management happens most of the time at the nurse's level upon assessment of medications. The hospice and palliative nurse is also the educator, the caregiver, the coordinator, the manager, and the expert in safe medication management. The expert. So how is polypharmacy managed? It is managed through the process of medication cessation, otherwise known as deprescribing. And so, deprescribing is the active process of reviewing all medications and considering the risk versus benefit in context of illness severity, advanced age, multimorbidity, physical and emotional capacity, life expectancy, goals of care, and personal preferences. This is a patient-centric approach. The practice of deprescribing involves a stepwise approach that is not about denying effective treatment, but reducing the risks and burden of taking multiple medications. Medications are assessed for primary or secondary prevention, as well as if they serve an essential function to comfort and quality of life, or do they serve a non essential function to the comfort or the quality of life. We discussed patients reporting a higher symptom burden with polypharmacy, and here's a little more literature that supports patients' wishes. So, 94% of patients said that they would stop taking a medication if their doctor said it was okay. I don't necessarily think the doctor would offer that option, but to know that 94% of patients who are taking medications are open to decreasing their medication burden is enlightening. That's almost all of the patients who take meds. Two-thirds of patients stated that they wish that they could take less medications. And so that's pretty eye-opening data, especially when we are trying to provide a patient-centered approach and looking at it from the patient's perspective versus that paternalistic model of medical care. And so where do we begin? This comes back to our assessment, diagnosis, planning, intervention, and evaluation. So this is our nursing process. And so using our nursing process to assess medications from a comprehensive assessment, assessing family and patient readiness, or that's the goal-oriented care, identifying a tool that will further assess for polypharmacy, plan and communicate within the interdisciplinary team, and then implement a deprescribing plan as we continue to assess the patient for adverse effects and/or improvement in quality of life. Normal nursing process. Phase one of this process is to assess medications. And so we give generally a lot of our care is provided in the community. And so many a times it's the phone call to the patients that say, I'm coming, please have all your medications out on the table. And then when you get there, your list says they're on 15 and they only provided you with 4. And so then we start to ask, okay, do you have medications in the bathroom? Are they at the bedside? Do you carry them in a purse? Are they in a drawer? Are they in your car? Do you have a second home or do you go to somebody's home, family member or friend's home where you may have extra medications? We also use the electronic health record for those patients in long-term care or assisted living. We assess for the signature or the prescription to include the patient's name, the dose, the frequency, the route, and the quantity. Those are usually all prepared for us on a medication bottle. We want to know what the medication is treating, when the medication was started, and if the patient doesn't know that information, the pharmacy may be a good resource to use. If the medication is a PRN med or an as needed med, we want to know the reason and how frequent is the med being taken. If somebody's taken a PRN medication for anxiety and they're taking it 4 times a day, it may be more advantageous to ask for something different. And how patients are taking their medications is also helpful. So this would include asking them to demonstrate how they use their inhaler or injectable medications, trying to time that visit so that you are able to observe safe use of medications. And then finally, is the medication helping you? A lot of patients will tell you, I don't think so, or they don't remember. Um, Phase 2 of the comprehensive medication review, um, we want to have a slight hint. We want to start to tip our toes in that water to investigate if this is going to be a conversation that is going to be accepted, right? Patients are oftentimes very attached to medications. And they're very attached to the provider who started them on the medications. There's that trust and relationship that's already been built. And if we come in as nurses and try to start taking things away, it starts that relationship off with distrust, mistrust, and confusion, concern from the patient perspective. And so we want to try to gather a loose timeline. So when did this start? Do you think it's still helping? Um, and assess for their readiness. So we want to start with the patient and the family first. And if they, one very simple question that I use often is just asking the patient or the family, if the patient's not able to answer, do you feel that you're taking too many medications? And so coming into that situation with curiosity versus a judgment of looking at that immediate list and saying, oh, you have 11 meds. This is polypharmacy. We're going to start discontinuing. Starting off with that approach of curiosity is going to help to build that trust to have the next part of this conversation. Listening to the family and the patient's goals and expectations around medications will also help to give the nurse some more information. And if they feel that there's too many medications on board, then the next question would be, would you like me to help develop a better plan? Or would you like to develop a better plan together? Making sure that the patient knows that this is their care that we're helping to facilitate and helping to navigate for them. It opens up a lovely door of collaboration with the patient being at the center. Phase 3 of this comprehensive medication review process is using evidence-based polypharmacy assessment tools to further identify medications that may be beneficial or may benefit from having a provider evaluate a little bit further to assess for appropriateness of continuation. A few similarities among polypharmacy assessment tools include asking what the medication purpose is, how the patient is taking it, if the medication is effective, and are there adverse effects or burdens from therapy, and communication within the interdisciplinary team. So this slide is a list of all the evidence-based practice polypharmacy assessment tools that we have available to us. And this is not a full comprehensive list. This is just some that are the most researched. And so I'm not going to talk about each and every one of them, but I want to just familiarize you with how did we come up with so many. And so the Beers criteria, this is my least favorite medication tool resource that we have. And the reason why is because oftentimes in the end of life and serious illness setting, it is not applicable and it was not made for that. This tool was created to be used in long-term care as a guide for providers for providing chronic care management. And so there's a very big difference in providing chronic care management and prevention of negative outcomes to we're at end of life and now our focus is on comfort and quality. And so a lot of those medications get a bad rap if they're used in our specialty. And that's my gripe for it. But it is a tool that is often referred to. And from a palliative perspective, from that non end of life perspective, it certainly can be applicable. We also have the Start Stop assessment tool, and this is organized by an organ system. So the Beers criteria is organized by class of drugs. The Start Stop tool is organized by organ system. And the takeaway from this tool is to stop potentially inappropriate medications and start appropriate treatment. So sometimes we want to stop a med because it's not effective and start a more appropriate med. This tool is not appropriate for patients with limited life expectancy. So this would be an appropriate tool to use for our palliative care population. We have the ONC-PAL assessment tool, and this was created, as you can imagine, for the oncology and palliative patients. And this tool is used for those with a life-limiting expectancy. We have the Good Palliative Geriatric Algorithm. This is most commonly used in long-term care. However, it is applicable and researched in the community setting also. We have the ARMOR tool, which is ARMOR stands for Assess, Review, Minimize, Optimize, and Reassess. This was generated out of Norway, and it was used in general practice in the nursing homes for general practice, so primary care. We also have the Stop Frail assessment tool. This is used for the population with life-limiting illness, and it organizes it through body system approach. So it's an assessment approach, a body system assessment approach. The medication appropriate index, this was created for a population over the age of 65. We have the less cron. This was a multimorbidity and chronic illness population. We also have medication-specific polypharmacy assessment tools. So our anticholinergics, our hypoglycemics, our antipsychotics, our benzos, our cholinesterase, and our proton pump inhibitors. And so needless to say, there is an awful lot of assessment tools out there. And how are we expected to make heads or tails? There's also further support I wanted to add in here. Living in, 21st century technological world, oftentimes we have that tool at our fingertips. And so I wanted to share with you two other assessment tools or assessment resources that may help. The deprescribing.org is started as a Canadian-based organization that offers evidence-based deprescribing guideline algorithms for medication classes and includes proton pump inhibitors, antiglycemics, antipsychotics, benzos, cholinesterase inhibitors, and then memantine or Namenda, otherwise known as. It also offers education for professionals and caregivers. So this is a really great tool if you'd like to provide your family or patient with a little bit more education on why or where we're getting information to say, hey, that medication may not be in your best interest. Let's take a look at it. Additional information can be found on MedStopper, and this is a web-based clinical decision support tool that accepts a list of medications and then will itemize that list or sequence it and help to determine this medication you should more likely stop versus this medication is less likely that you should stop. So these are two fun little tools that you are able to use, and I have not checked myself to see if there are apps for these, but I'm sure they're very easy to use. So where do we go from here? Which tool is the best one to use? There is a lack of consensus on this. And so we certainly want to try to tailor the tool to what and who the patient require. And the reality of all of these tools being present and not one being better than the other is just a reinforcement that everybody is an individual. And if we were to use an algorithm, one systematic algorithm or one approach to prescribing or deprescribing, it's not going to align with that patient-centered approach and that patient-centered care, that individuality that each of us deserves. And so I wanted to share with you, there was a comparison study that was done using two validated tools, and it looked at the ONCPAL and the Stop Frail tool. And this was an expert panel review of reviewed medication lists of 50 patients who were receiving palliative care. The average number of medications for each patient was 11, and 19% of the medications were deemed inappropriate. Both tools were applied to all patients, and neither tool was inferior or superior to the other. The ONCPAL tool, again, just uses medication by class to assess appropriateness. And this was done in a cancer population who had less than 6 months of life expectancy. So here we have a study that says that they were receiving palliative care, but in reality, we know that this was hospice care that this group of people were receiving. The Stop Frail tool assessed body systems in patients who had end-stage irreversible disease, less than 1 year of survival prognosis, so again, very close to that hospice population, severe physical impairment or cognitive impairment, or symptom control was the priority versus prevention of disease. And again, there was no statistical difference between either of these tools. So what is the research lacking? So research lacks a clear, concise tool that can be used across all patient populations. It also lacks a tool that is applicable to those who are younger than 65. So our palliative care population, a lot of our palliative patients who are younger than 65 would not be appropriate to use some of these tools. There are no tools out there that also help with those who have a highly curable or treatable disease. And it may be a moot point to think that if somebody has a highly curable or treatable disease, that their medication burden would lessen over time as they get back to a state of health and wellness. But as we know, once patients are prescribed medications, oftentimes they are not discontinued. Tools also lack addressing our underserved populations, and they continue to be poorly represented throughout all research. And this includes looking at race, ethnicity, homeless status, veteran status, and poverty stricken, amongst a few. So let's take a look. We're going to take a look today at 3 tools a little bit deeper in detail. We're going to take a look at the ONCPAL, the Stop Frail, and then another tool that was not yet mentioned. So the ONCPAL identifies or organizes medications in class and identifies 8 areas of medication. So it looks at if a patient is taking aspirin, is it a primary or secondary prevention? And that's a provider level decision, not something that we would necessarily be able to understand, although we can simply ask a patient, did you start taking this medicine before or after your heart attack? That helps us to determine if it's primary or secondary prevention that we're using it for. Lipid lowering medications, hypertensives, this includes our ACE inhibitors, our sartans, our beta blockers, our calcium channel blockers, our thiazide, our diuretics. It also includes our anti-ulcer medications. So those are our omeprazoles, pantoprazoles. It looks at oral hypoglycemics, osteoporosis medications, vitamins, minerals, and the complementary and or supplements, herbal medications, or adaptogens. And then the Stop Frail. So this looks at organizing medications by the body system in which they function. So this identifies 10 areas or systems of assessment, and the general area includes any drug that the patient persistently fails to take or tolerate. So if a patient is not taking their aspirin and they haven't been for 2 years, it may be a good idea to ask if we can discontinue that. Certainly not providing any benefit. It also includes medications without a clear indication. So if the patient says, I don't know why the doctor started me on this, that's certainly something that we can bring to the table of if they need it or not. Some things may be clear that they need and some things may not. It also looks at the cardiovascular system, which includes the lipid lowering medications, but also antihypertensives like our alpha blockers. It also looks at terazosin, and that's Flomax. It looks at the coagulation system and aspirin and clopidogrel, otherwise known as Plavix. It looks at our central nervous system, looking at all antipsychotics that a patient has been on for greater than 6 weeks. And memenedine. This is Namenda. Our GI system includes the proton pump inhibitors that patient has been taking for greater than 8 weeks. Histamine 2 blockers that have been greater than 8 weeks, or antispasmodics, and that's due to an anticholinergic effect that generally does not work well in an older body. It looks at the respiratory system, looking specifically at theophylline, which is a very old medication, not commonly used nowadays, and the leukotriene antagonist. And so that's our montelukast or our Singulair. It looks at the musculoskeletal system and calcium supplements, osteoporosis treatment, anti-inflammatories greater than 2 months, including steroids greater than 2 months. And that's looked at from a risk versus benefit side effect. The longer patients are on those medications, the higher the risk of harm is. And certainly if they're providing patients with high quality of life, it's not something that we want to take away from them. The urogenital system, this is the benign, the BPH medications. Those are the Zosins, the terazosin, the Flomax, the Cardura, the doxazosin, which can sometimes be used in cardiovascular disease. It also looks at atropine, scopolamine, and ipratropium. And so those are medications that also overlap in our respiratory system. It looks at the endocrine, oral hyperglycemics, and the ACE inhibitors, the ARB inhibitors, and any oral estrogen supplementation that a postmenopausal woman may be on. The miscellaneous section here includes multivitamins and antibiotics that are prophylactic. So luckily enough for us, our specialty has a preferred tool that is endorsed by the NHPCO, and so we're going to spend a little bit more time talking about this tool. The NHPCO, or the National Hospice and Palliative Care Organization, also has a deprescribing toolkit that any clinician can use and access for free. This tool is specific to hospice patients only, however. And it's used as a companion to the medication decision tree that is not provided in this presentation, but is found on the NHPCO deprescribing toolkit. And it goes along with the hospice formulary guide. So this is wrapped up and packaged for our hospice folks. So polypharmacy is defined by NHPCO as a patient having 3 to 5 or greater medications. The recommendation is that the clinician use the decision-making tree and flow charts provided in the toolkit to help guide discontinuation. Discontinuation of medications are recommended if a patient is not taking medications as prescribed. They're also recommended to decrease in frequency or dose versus completely eliminating, and that is a taper method. NHPCO toolkit also encourages assessment of medications for its ongoing indication and need versus preventing disease progression. So this comes back to, as our body changes, so should our medications. And as we know, in the last year of life, the human body is changing at a rapid rate. And in a catabolic state, a state that's constantly breaking down, unlike our first year of life where we are in a building state. So pharmacologic areas of focus in the deprescribing toolkit include antiplatelet, anticoagulation, dementia medications, respiratory inhalers, and statins. So taking just a little bit of look at this a little bit deeper. So providing some rationales for why. Why are we looking at antiplatelet and anticoagulations as a polypharmacy risk for patients? Well, very easy. There's a high risk for bleeding. We want to know, is the patient, is it still indicated? Do we really want to prevent them from having a stroke if that's not a high risk factor for them and it's an overall lifestyle and life improvement? We really do care about and are concerned for falls and the high rate of injury. And we also need to be mindful of that aging and declining body. So medications in this class would include aspirin, clopidogrel, which is the Plavix, and Coumadin, and Apezaxban, or Eliquis, excuse me. I knew I was not going to be able to say that generic name very good. But additional assessment tools can further help a provider identify if it's necessary or not to keep patients on anticoagulant medications. There's a lot of fear of taking patients off of these medications. Dementia medications, and the reason why we want to take a look at dementia medications is because of lack of evidence and lack of response from evidence. And so this can be very difficult to gauge a lack of response. And so we may rely on our caregivers or the original prescriber to ask questions such as, when did the drug start? These medications are not shown to be to provide any help after 5 years. And then asking caregivers and family if they feel that the medication has helped. And so sometimes they'll say, yes, dramatic difference. And certainly we don't want to take away anything that's helping to provide quality of life. But oftentimes we'll find that the answer is no, they did not. And do we still think the medication is effective, right? Once we take away that medication for dementia, patients don't automatically decline. These medications are used to slow the progression. Well, if somebody is already at a FAST score of a 7A on our functional assessment staging test, then the medication is no longer effective because patients are at the end stage of their disease at that point. There's no longer any ability for medications to stop or slow down progression. And we also want to honor freedom of choice. In my practice, this was a medication that oftentimes families are very hesitant to stop. And so always, the option is the medication doesn't go anywhere. If you, really feel like there was a dramatic change, you can always start it back again. Although the chances of either of those are very slim. And so looking at the respiratory inhalers, these recommendations include all handheld respiratory inhalers. Those are our Combivent, Advair, um, all the other ones are slipping my mind right now. But the recommendation comes because of the high incidence of misuse. So 8 out of 10 patients do not properly take their inhalers. And research does not support using these medications in end stage disease. So all the research that was done on these medications for efficacy were done at the beginning of disease. And again, once medications are started, very highly unlikely that they get discontinued. They're also used to slow progression. So if we get somebody in hospice who's end stage COPD, well, their disease is at the end of their stage and there's no longer the ability to stop the progression. There's also no impact on comfort by using these inhalers, and the recommendations are to switch to nebulizers and or oral steroids for comfort for symptom management. Daliresp is another medication that falls under this category, although it's not an inhaler, it's an oral medication. And the research shows that Daliresp is only effective in 6 to 12 months after taking. And so if you have a patient who is within that 6 to 12 months and they said they feel like they got an improvement, we don't want to stop it. But if they're in 2 months and they say this medication hasn't done anything, certainly it's up for conversation to discontinue. Type 2 medications, oral hyperglycemics. This comes from the recommendation that we actually want our older and seriously ill folks to have a higher blood glucose level. And so our A1C goal is 8.5, and that gives an average glucose of about 200. People feel better when their sugars are a little bit higher. And we want to decrease their risk of hypoglycemia, which could be fatal and cause a high risk of hospitalization, something that we also don't want any of our hospice patients to have. And statins. So statins, if you have been able to pick up, statins is the one consistent area and medication that is continuous throughout all polypharmacy assessment tools. And that is truly because the research on statins is just not as strong as we want them to be. And so the recommendation also comes from the likelihood that we do not have time in our favor for the medications to be as effective as the maximum amount of research can show, which is still pretty low. And so we also want to avoid using medications for primary prevention. And sometimes if somebody had just a high cholesterol back in their 50s and they've never had any cardiac events, that statin would be considered a primary prevention versus that person who got started on their atorvastatin after a cardiac event. That would be secondary prevention. There's also a high rate of adverse effects with statin medications, including muscle cramps, pain, weakness, and that overall increases falls and decreases quality of life. Another study was done that showed that patients actually had a decrease in GI symptoms once statin medications were stopped. And so medication works throughout our entire body, not in just one spot. And so overall, we see assessment tools help to identify those patients with comorbidities, those who use multiple medications, 5 to 9, or have similar types of medications for one illness. And we use a risk versus harm approach when we're looking at identifying. We go to our nursing diagnosis. So NANDA does not have specific medication related diagnoses. Again, medications thought to be under the medical model. For injury, impaired adaptation, if a patient is not taking it very well, or they, are having a hard time coming to terms with the fact that they're at end stage and may no longer need some medications. There's also the risk for caregiver role strain. Caregivers oftentimes are the nurses in the homes when we are not there. And compromised family coping. Sometimes families really take it hard when we talk about taking away medications in the hospice setting. It's just one loss after the other, and medications oftentimes can be viewed as a loss. So the S-bar approach, as we move into the planning phase of managing polypharmacy, we must remember communication is paramount to success among all healthcare team members. And so S-bar is one of many communication frameworks that helps to streamline that communication. We begin by contacting the provider to notify of the comprehensive medication assessment, including the assessment for polypharmacy and at demonstrating a risk of harm to the patient. You want to also give the background information to include when hospice enrollment happened, the patient's status, and discuss the patient's goals. This is patient driven. You want to review the medications that were found to be in question, and also help to support help to discuss the tool that you used. Gives a little bit more validity. You also want to make sure the recommendations you also want to be the person to make the recommendation that we discontinue or develop a different plan going forward. So some challenges, this certainly is an area of a lot of challenges. And so physicians are not educated on how to deprescribe. That is a very big challenge. Lots of people teach us how to prescribe medications. Not a lot of people teach us to deprescribe. It's a learned process. So this is learned. Seriously ill patients have multiple providers. Therefore, it is, who takes the call on this? Who is it? The specialist? Is it the primary? Is it the cardiologist? Who wants to take ownership of saying, no, they don't need that anymore? Nobody does. Patients' expectations. So they have the fear of abandonment, the idea that prescriptions fix everything, not wanting to stop despite sharing education and facts. An organization constraint, including lack of time. It takes a long time to do one of these assessments and do it thoroughly and to follow up with it. Also, fragmented care and lack of access to expert guidance, as we've seen, such as a pharmacist or a palliative specialist. And there is that, again, lacking one concise tool to use. And so planning for deprescribing, we obviously start with safety first. And so this is a list of medications here that we want to just pay special attention to in how we start to deprescribe. So how we start to take these medications away. Antihypertensives, antidepressants, anxiolytics, anti-Parkinson's, antipsychotics, anti-dementia, anti-seizure, steroids, and opioids. These medications should never be abruptly stopped. These need to have a slow approach to tapering, and that's for comfort and safety. And so planning includes sharing the plan with the patient and family, bringing them into the plan, giving them understanding, opportunity to ask questions, provide teach-back method, prioritizing the medications. And so we want to start with the most burdensome, those that are unsafe. You may want to begin with first. And then doing one at a time, so stopping one medication at a time to assess for effect and or adverse events. And then updating the care plan. So this sometimes is often overlooked, but as we know, we have lots of team members on our team, and we want to make sure that those care plans are up to date so that if one of our colleagues are coming in to help support us, that they know exactly what the plan for that patient is. And so evaluating the deprescribing plan. Evaluation of patient and adverse effects is medication and patient specific. And so each person responds differently. No medication is suited for every body, and no body is going to respond to that medication the same. Reassessing the quality of life by asking, how do you feel? How do you think this plan is going? And you want to continue with the basics of that nursing assessment, including vital signs, mental status, and going through our symptom burden. So I'm going to briefly talk through a case study. And so this is of Mr. Palmer. He's a 64-year-old male with a recent diagnosis of metastatic non-small cell lung cancer. And he has a past medical history of an MI, diabetes, obesity, COPD, and he's a tobacco user. He currently lives at home with his son, who is his primary caregiver. And Mr. Palmer was laid off 6 months ago. He's being admitted to palliative home care from the hospital after having chest pain, upon which at the time he was diagnosed with a left pneumothorax. So he requires nursing care for chest tube management teaching, nutrition education, as he had a 15-pound body weight loss in the last 90 days, and teaching of chemo and radiation and symptom management. So patients' goals are to fight this godforsaken disease. I want to continue to feel stronger each day and be able to help with house chores. So having that meaningful sense of purpose back to his life. This is Mr. Palmer's medication list. He has atenolol and simvastatin and lisinopril and glipizide. He has glargine insulin. He has new lactulose, so the medications that have an asterisk are newly prescribed from his hospitalization. He also has his salmeterol, his formoterol. One of these is Symbicort, the other is Advair, and he has his albuterol puffer. Newly started on omeprazole, dexamethasone, and oxycodone. Mr. Palmer also reports that his 2 inhalers are not in the home, and that is because he was unable to afford them once he lost his job, and he has not had them for at least 2 months. And so the assessment, he is cachectic, 15-pound body weight loss in 90 days, that's a lot. He also complains of intermittent dizziness, his having fasting blood sugars in the 60s, and his highest blood sugar is 110 at night. He's got a poor appetite, but he reports drinking lots of water. He's intermittently dry cough, negative for any blood. He reports insomnia, fatigue, and malaise. His blood pressure is low, his heart rate is low, and he has 3 out of 10 pain to the left flank. Mr. Palmer also states when we asked about his appetite, he stated, "It's been poor. I feel full before I even sit down. My medications are my meal." And so looking at the comprehensive medication review, we have all of the SIG there. Previous slide showed the reason or the why he's taking it and for how long he's been on them. So 12 medications are identified here, which would trigger a polypharmacy assessment review. So let's take this to a tool. We are going to pick a tool, any tool that would be applicable to Mr. Palmer. So for this case, I chose the stop frail for no other reason. And so the general, again, looks at any medications that the patient persistently fails to take. Cardiovascular includes lipid lowering, alpha blockers. Coagulant, he's not taking any. CNS, he's not taking any. His GI, so he was started on omeprazole, and that was less than 8 weeks ago. The respiratory, he's not taking either of his inhalers and hasn't been for 2 months. Musculoskeletal, he does take a steroid, which he was started on less than 2 months ago. He's not taking any medications for urogenital, and his endocrine medications include lisinopril and atenolol, as well as the insulin and the glipizide. He's not taking any supplements, vitamins, or adaptogens. And so when we come out of this assessment tool, we're left with looking at atenolol, simvastatin, lisinopril, insulin, glipizide, and the 2 inhalers that he does not use. So the diagnoses that we're going to come up with here is risk for injury due to multiple medications. He's at increased risk for falls because of the dizziness, the low blood pressure, the low heart rate. I also added noncompliance to medication regimen, and even though this wasn't a patient driven reason why he's not taking it, it's still a nice diagnosis to use because it helps to highlight that social determinant of health. The reason why the patient's not taking it is because of cost, and that should be documented. And the plan. So implementing this plan should include Mr. Palmer and his son, as well as discussing among the interdisciplinary team. And so here's an example of the SBAR approach with Mr. Palmer. Dr. Sparks, this is Rebecca, the palliative care nurse for Mr. Palmer. I'm completing his home care admission and have assessed that he has several medications that may require adjustment or discontinuation. Mr. Palmer is found to be hypotensive, have low blood sugars. He's also reporting fatigue, dizziness, and malaise, muscle aches, muscle weakness. I'm questioning if it's appropriate for him to continue his atenolol, lisinopril, simvastatin, insulin glargine, glipizide, salmeterol, and formoterol inhalers. I'm recommending a new plan as patient is feeling the burden of multiple medications. And Dr. Sparks is in agreement with our recommendations and gives us this deprescribing tool. And so first we're going to look at those safety medications, the insulin and the oral hypoglycemic. These are medications that could hasten a death and certainly decrease his quality of life. And when we eliminate them, he's likely to feel a little bit better when his blood sugars pop up. So addressing the medications that can have the most risk for injury should be first. stopping one medication at a time is another rule to follow. So for Mr. Palmer, we're going to stop both his glipizide and decrease his glargine. We can do those at the same time, helping to boost those blood sugars up. We're also going to, the next day, so we do that on day 1. Day 2, we're going to have him decrease his amlodipine. Day 3, we're going to have him stop his lisinopril, or excuse me, decrease his lisinopril. Day 4, we're going to have him have the nurse visit to reassess the plan. And day 5, we're going to stop the simvastatin. The inhalers are not an issue at this time because he was already discontinued those. So day 3 revisit comes up and Mr. Palmer reports feeling less fatigued. Yep, usually happens when we bring up that blood sugar. Fasting blood sugars are in the 90s, so that's great, right in normal range. At the 1-week follow-up, Mr. Palmer reports having less malaise. His vital signs are in normal range as well as his heart rate. His fasting sugars are normal, still under 200 in our target. And he reports having more energy. Improved appetite. He reports coughing less, decreasing that lisinopril helped there. And he's only using his albuterol 1 to 2 times a week. Well, that was a mouthful. And so I thank you for listening to me. And now I would love to open it up to any questions.
Rebecca, I don't know if you want to take your slides down so that way the participants will be able to see each other more. And I'll go ahead and stop recording at this point.